Good afternoon, everyone. Welcome to the 2022 Aspen Ridge webinar series. My name is Gina Thorne, facilitating today for Dr. Philip Hemphill and for Aspen Ridge. Today, we'll be talking about exploring boundaries and ethics in clinical care. First, I'd like to say a special thank you to All Points North for co-sponsoring with us on this webinar. For those of you that are new to Aspen Ridge, here is our treatment philosophy. We believe that mental health, trauma, and family are the root of recovery. We focus on healing these systems and provide each person with the tools they need to grow and sustain in long-term recovery. Who is Aspen Ridge? You will see that we have 5 key value statements that we focus on. We focus on community, family systems, integration, inclusivity, and people first. To learn more specifically about these areas, we invite you to visit our website to learn more. Just a few housekeeping for those of you that are watching today. It is important that we have documentation online that shows that you have participated in the webinar. And so we will be sending out a post-survey evaluation after the webinar to complete. Please be sure to provide us with your contact information so that we can send your certificate to you. This webinar is approved by NADAC for 1 CEU. Participants must participate in the webinar for a minimum of 45 minutes in order to receive your certification. If you're unable to attend the 45 minutes, you won't receive the certificate with the NADAC credit, but we can provide you with a certificate of completion. Please let us know if for some reason you're not able to attend the entire workshop. And following the webinar, you will receive a certificate by email, and we need to make sure that we have your correct email address. If you don't receive the certificate by Friday, please contact me at gina.thorne@aspenridgerecovery.com. I'm very excited today to introduce you to Dr. Philip Hemphill, Chief Clinical Officer for All Points North. Dr. Hemphill has a very long history in working in the field of addiction treatment. He received his master's and doctoral degree from Tulane University and has had faculty appointments at Jacksonville University and Loyola University. From 2003 to 2015, Dr. Hemphill was a consultant and the director of the Professional Enhancement Program at Pine Grove Behavioral Health, where he was responsible for the management and clinical supervision of professional patients in an intensive outpatient residential setting. Throughout those 12 years, he moved through the system, working in every capacity from consulting, manager, leadership coach, and strategic planner. Most recently, he is an author. He has several books that I'm sure he'll be discussing with you today in our presentation. I had the pleasure of working with Dr. Hemphill a few years ago when he was the Chief Clinical Officer at Lakeview Health in Jacksonville, Florida. Again, I'd like to say a special thank you to All Points North for co-sponsoring with us on this webinar and for Dr. Hemphill's time in talking with us about ethics. If you're interested in learning more about Aspen Ridge or to access additional information about our upcoming educational opportunities, please visit us at aspenridgerecovery.com. And if you are interested in being on the mailing list for future webinars, please be sure to reach out to me and we'll be happy to help you. With that, I'm going to go ahead and turn this presentation over to Dr. Hemphill.
Thank you, Gina. Can you hear me?
Yes, I can hear you.
Okay. I'm going to share my screen. Can you guys see the title slide?
You might want to put it, there we go. Perfect.
All right. It's full. It's the full screen.
It is.
Okay. Can I also start my video?
You sure can.
It's saying it won't let me. It said the host has stopped it. So, but that's okay. If you just want me to show my picture, I can do that too.
Yeah, let's do that. Unless you want to see your face, we can show your face.
That's fine.
Okay.
No, that's fine. All right. So one last thing, Gina. Do we have the ability to break into small groups, or should I just ask the questions and then people can respond?
We can do it that way, and I can field those questions for you.
Okay. All right. Because I have a couple of exercises where I want some participation, if at all possible. But thank you, Gina. It's wonderful to be back in your presence and to work with you collectively in Aspen Ridge. Wonderful stories and life-changing events come from Aspen Ridge. So very happy to be a part of what you guys are doing. there. So this particular lecture, I hope to accomplish a few things here and looking at both the ethical and clinical issues related to care. I think you've mentioned my relevant financial relationships with personally myself as a consultant, All Points North, and I'm currently a consultant for the Ohio Physician Health Program. And I mentioned these in the brochure regarding, looking at both not only us as individuals, but us as collectively as a group of mental health providers. And we may not be able to discuss things individually, but we'll hopefully have a collective conversation about the boundaries and everyday practices related to the boundaries that I'm going to be talking about. At the end, I want you to understand your own sort of issues related to how you developed your ethics and your professionalism. I want to look at a model for the making decisions based on these ethics. And then also the fact that we're all vulnerable to some stress cycle and our commitment to understanding that and how to intervene with this. This is really about our perspectives, the way that I, through my lens and what I see today. Obviously, we all bring our different life experiences, our different developmental experiences, our different clinical history, our different populations that we work with. So I ask you to think about a broad lens here today, and that some of what I'm going to be referring to may be more appropriate for urban settings as opposed to rural. Some, what I'm referring to, may be more appropriate for adults versus children or a geriatric population. So I just ask people to recognize that this is coming through me and the way I see it, and that obviously you have your experiences, and then there's ultimately the way it really is. I think that we're seeing a lot today, just to kick this off, with the reality of a tremendous number of decisions having to be made, exponential from things that we would just sort of take for granted in the past. And so we have this low, continuous level of stress that people are experiencing. And it's not only our clients who are coming in and needing to assistance with a lot more decisions in their life, but ourselves, we're having to make these decisions about, regarding, should I stay at home? Should I have a hybrid job? Should I seek out another employer? Should I stay where I'm at? What about, my family? What about those ones who may be at increased risk for different types of disease states and stressors? So we're having to make a lot more decisions these days, and just trying to remind people that most decisions can be undone, even with a thoughtful preface, like where we can kind of think about the possibilities. And, some of them, require commitments, and sometimes it's not bad to have a commitment. So I just ask you to reflect briefly on your own in the past couple of days here. What types of decisions have you had to sort of pause before you made them? What types of decisions may have created some pain points? What types of decisions were you experiencing paralysis, where you couldn't decide? And then what types of decisions that you made that just created a tremendous amount of joy? I'm just going to have us reflect on this for a second, because the reality is that decisions are above and beyond. We're having to make a lot more decisions as mental health providers, whether it's checking in with each other and seeing how each other is doing, and then all of a sudden finding out that other people need our support. That's some decisions. How do we respond to this need for support? Whether it's, again, with regards to, do we take this particular, CME opportunity? Is it a webinar? I'd rather be in person. I'd rather be online. Is it easier for me to do? Can I multitask while I'm in this thing? So there's a number of variations here. But one of the things I encourage people is to check in with each other. And just the simple idea of saying, how are you doing? Is a way to sort of alleviate some of the stress of the decisions, and just a pause to have a connection instead of just keep going. I think that, we sometimes have to be reminded that what led to us being considered a professional, because we've been able to master a certain body of knowledge and skills and practice science, as well as being creative, and that we're governed by a code of ethics and the promotion of good. Society really wants and needs professionals. We're essentially a repository for a lot of the pains and ills that society experiences, and may or may not have the skill set to manage these. I think a lot of mental health has been pushed out into the public. And I think what we see is a lot of people don't really have the skill set to understand and manage these things. So while they can be supportive and offer feedback and very constructive in these things, it's not necessarily a professional intervention. And so society looks to us to have a higher level of trustworthiness, so that they can feel the sense of safety, the sense that they can seek us out, that we have the ability, the skill set to manage them and to assist them. Again, we're both responsible for ourselves as individuals, but we're also responsible for collectively the groups that we belong to. Essentially, making it into the realm of professional world is actually, you've been anointed. You have a certain level of aptitude and conditioning that you've mastered, and it comes at a cost. There's sometimes feeling that you have to be superhuman to maintain your professional status. And then there's always an illusion that we have this this objectivity in our profession, when in fact we're human beings that are performing this, and we're vulnerable to difficulties at times with trust and looking at how we can deny ourselves and displace our own feelings. In my experience working with professionals, literally thousands over the course of my career, I've seen professionals have difficult time accepting help and being open to it. And because part of it is that we sort of are used to being in control. We know exactly how to get things done. We know what our schedule is. We know how much we have to achieve. What are the barriers for us achieving? What are the opportunities for us? We know how to manipulate rules. We know just how much that we have to document. We know what we have to document. We know how long we have to see people. We know, there's a certain level of grandiosity. I mean, heck, just today, I have a couple dozen of you showing up for this. I was invited to give this talk. It makes me feel positive and powerful a little bit as a professional. The fact that someone is seeking out your guidance and your sage feedback brings forth a natural sense of I'm a little bit omnipotent here. We have a tendency to intellectualize, meaning that superior defense mechanism of explaining things away, like I can just understand this by explaining this. Discounting our own feelings and needs. Oh, that's not really necessary. I don't need to take a break for lunch. I don't need to get up and walk around. I don't need to take a vacation. These types of things. I don't really deserve this item to purchase. So there's a tendency to discount oneself, being afraid that there may be exposure if we make ourselves vulnerable. We can sort of always justify things like we're just protecting others. We also have a fear of intense emotions, and sometimes it's difficult to let people know in an assertive way that I'm upset, or I don't appreciate, you not paying your bill, or you being late, or you speaking to me this way. These are some things that I've seen before. And also ultimately having this sense that we fear disapproval from our peers and colleagues. These are just some of the ways that I've seen professionals have difficult time with feedback at different times. Truly, though, we're essentially inoculate ourselves in this industry to where it could be diagnostic of PTSD. Just the things that we get exposed to on a routine basis are not necessarily what the public is getting exposed to, despite what they watch on television or videos they see. They don't live this. They just sort of have this vicarious observation. They're not really living the impact that some of these videos or experiences that people witness have on others, and the ripple effect that occurs across generations. Some of this is definitely diagnostic for professionals. It's good to have a clear understanding of what our, external and internal rewards are as professionals. It's great to seek out esteem and status and privilege and power and income. There's nothing wrong with that. That's why we sort of move into the professional realm. Now, we could say, well, I'm just in this for the altruism, and that's I saw that on the earlier slide. But in fact, we want to recognize that it's okay to have these as well. Internally, we really generally like to nurture our legacy of relationships. And we think about the olden days. We think about people that we trained with. We think about some of the experiences we had as professionals at different stages. And ultimately, that internal also comes from that service to others. That's that altruism and choosing your vocation, that you feel like you had a choice. It's okay to sort of take pride in our endurance, the fact that we can see the number of clients we see, run the groups we see, do the assessments that we can do, and have this sense of responsibility of helping others. One of the issues that I've seen with people in professions that have difficulties is that they sometimes think that if they just do more, they'll compensate for any difficulties that they're having. We all run up against different developmental stages, different life cycle experiences, different stressors that sometimes we fail. Sometimes we have difficulty overcoming. And so sometimes I see people have a difficult time reaching out and asking for help. And so what they try to do is work harder and do more. And somehow that's going to cure the need to ask for help. Sometimes training can be the problem. So, people get in their early training or supervision. These are some of the issues that we could see with younger generation coming out of the training. We could see a lot of competition, isolation, cynicism, just lacking limits, lacking balance. These are just some of the problems that happen during the process of training. So essentially, after you get out there in the field and you start practicing your profession, you have to sort of adjust and overcompensate for some of these problems that occur during the training experience. One of my colleagues, Jess Montgomery, talks a lot about the idea that we kind of fall down this rabbit hole when it comes to, our profession. And at a very young age, we start to sort of make these decisions about our professionalism. And all of a sudden, we find ourselves falling down and not really being able to grab hold to anything and ending up in a wonderland that we try to wake up and say, did I really get here? How did I really get here? And is this really where I want to be? And essentially, a lot of people, as we move through profession, you can see probably over the course of time, about 50% of people exit out the profession. They realize this isn't really something I wanted to do. And then, you have a number of people moving forward. But it is a bit of an experience of sort of falling down and not being fully prepared for maybe what you were trained for or what you thought you were getting into, as opposed to what you're doing today. And so what ends up happening is that there's competing needs of all these areas. And again, sometimes difficulties with balance. And then, today, when we don't really tolerate, infractions as far as ethics go and boundary issues, that it's not really an excuse anymore to say, I didn't know the rules or I was unsure of the consequences. We're basically a self-selected group. The types of things that we sought after in our profession and our mental health field and our pursuit of our graduate training sort of allows us to sort of move forward. A lot of people end up with type A. If you could see me, I don't have a bow tie on today, but Gina can attest that I like wearing a bow tie for presentations. And I think that a lot of people in the professional world sort of migrate towards this type A behavior. And in fact, during the training years, you could see, most of us have this preoccupation with detail. We don't like to get things wrong, this perfectionism. We may constrict our affect, like I've already mentioned. You may have difficulties connecting with friends because you're so busy with your training. You may sort of have like some, intellectual or just a sense of superiority, and then it may impact your self-image. But we have to watch that if we don't look out, that we could really fall into some of these diagnostic categories if we have too much of those. It's probably good that most of us probably fall under the obsessive compulsiveness. It gets us through our graduate training. It gets you through your professional life to make sure your notes are done at the end of the day, your treatment plans are done, you're responding to phone calls, these types of things. I mean, most people in the professional world have some traits of obsessive compulsive. A lot of people show up and say, I really didn't think I had a problem until it was a problem. And in fact, we're expected to cover a much broader range of work with people these days and doing sort of this health home model, which isn't physically a home, but it's a sort of metaphorically, as a mental health provider, we're expected to be able to provide all of these areas with regards to transitions of care, support for both the individual and the systems, referrals, health promotion, and all this coordination. I think that a lot of people get into this idea that somehow I'm supposed to have this idealized value system. And while we're held to a pretty high standard as professionals, I think the reality is we all are human beings, and we have to sort of recognize that we have a realized sense of values that we really adhere to, that we may have some contradictions, we may have some difficulties at times between our values and the ways in which they're expressed. But idealistically, we want to have, a public self that mirrors our private self. We can't have behaviors in our private world that aren't represented in the public, and vice versa. We can't have public behavior that's not represented in our private. I think ultimately I'm a social worker, so I like to embrace the NASW, looking for justice and service and, the importance of a relationship and maintaining integrity and maintaining a certain level of competency. And the wonderful richness of looking at the diversity of our profession and bringing in cultural competence, which isn't, necessarily we need to know every single thing about every culture. That's impossible. We have to recognize that we're learners, we're lifelong learners, and we can learn from the people around us, whether it's a geographic difference, whether it's a socioeconomic, whether it's an intellectual or just a physical disability. There's all different types of ways that we have to take a position of learning, which is really recognizing cultural competency. Boundaries are very popular these days across many different industries, and people just promoting these things. We have to recognize that we come into the world with an understanding of our boundaries, and our developmental experiences inform our boundaries. So that plays a major part. Then we start to have experiences as far as what I expect from others and what I expect from myself. And then out of this awareness, we have the capacity for understanding our boundaries. Now that varies for all of us, because then we go into a profession where we're all expected to adhere to certain types of boundaries, at least within a certain realm of flexibility. So, ultimately, ethics are about doing good, not doing harm, giving people choice, being fair and equitable, and being loyal to people and not abandoning people. So doing the right thing, there's many different codes of ethics, depending on what your professional credentials are. And it's ultimately about encouraging and promoting autonomy and beneficence and non-malfeasance, and making sure we're doing what we say we're doing, and then offering up the opportunity for justice. And so, promoting autonomy and independence, what we do is ultimately fostering this. We're doing good, we're not doing harm. And so we're not taking advantage of people. We're in a trusting relationship, and we have responsibility, and fidelity is about the follow-up and making sure we say what we're going to do, and we're committed to that, and we're measuring that. And so boundaries are essentially this movable, highly context-dependent experience. So in certain settings, physical touch may be more appropriate. So if you're working with children or the elder population, it may be more appropriate. If you're working with criminals, let's say in a prison setting, the physical touch may not be the appropriate. If you're working with victims of abuse, physical touch may or may not be the appropriate boundary there. So we have to recognize, depending on the context and the state of our society, that these things are movable and they occur over the course of time. There are boundaries. There are many different people that have to adhere to boundaries. They don't always apply to therapists and patient. The same boundaries we have may not be the same to student, teacher, and employee, employer. One of the easy ways to look at boundaries is to think about what are like our time boundaries. Like, are we going over with people? Are we cutting people short? Are we late for appointments? That's an example of a boundary. Our role. So I'm in the role of educator for the next hour, but that's a lot different than my role as a therapist or a group facilitator. I have different responsibilities as a group facilitator than I do as an individual facilitator. I have different responsibilities as an assessor than as I do as an academic. So we have different roles as well. Our space needs to be a boundary. So the way we decorate our space, if people are coming into our office, if we're online, like just now, before I realized we weren't going to be on video, I blurred out my background because I'm in my home office and I didn't want you to see my background. So that's an example of boundaries regarding my place. What about gifts? For some people, it's cultural issues related to gifts. And so we have to look at, would accepting this gift be more detrimental than rejecting the gift? What is the value of the gift? What is the meaning of the gift? What is the timing of the gift? So we have to recognize that we can't just have a blanket statement about a lot of these different boundaries. I think the issue around language, the more casual we are with our language, probably the more relaxed we're becoming with our boundaries. I'm not saying we're not human beings in our relationships with our patients, our clients, the individuals we're working with, but we have to also maintain a certain level of competency, and our language can be an indicator of our boundaries that we have. And then obviously there are different cultures that we should be some level of awareness and understanding and be teachable, as well as geographic areas that I've been mentioning. Some of the factors that I've seen impact boundaries is if a clinician and a client have shared issues, if there's addiction that's shared, if there's abuse that's shared, if there's been absent role models that's shared, if there's similar or different orientation or religious or racial backgrounds, different people's understanding of recovery. So these are some potential areas where I've seen impacts occur. If there's one thing you really take from this is this quote about special treatment. Anytime as we're in a relationship and doing our work day in and day out, if we sort of have this sense that somehow we have a special relationship with this individual, we have to really step back or get some consultation, because this can lead to boundary issues. So just if we start to, in our mind, create this special relationship or this person, if this person calls, please contact me. You can't really take this call. I'm the only person that can really manage this person. That's an example of someone needing some consultation about their idea that there's some kind of special treatment going on. Again, if we're letting sessions go over or ending them early, we need to sort of have some awareness of that. Any intense feelings that we start to have towards clients can also be an indicator of our boundary issues. Now, if we look from the client towards us, they oftentimes place us in a parental or an authority figure role. They may eroticize us. They may be passive aggressive towards us. They may have this sense of brotherhood, sisterhood, theyhood, wehood, and the loyalty factor. Nobody will really tell. We got the same orientation. We have the same interests. We're from the same religion. We're from the same social organization. So nobody will really tell. We can sort of have this unique experience that often is pushed upon from individuals that we work with. These are just natural. These are just normal. It doesn't necessarily mean that you're doing anything unique. You're doing anything special. These are to be expected in the therapeutic relationship. It's how we manage them that becomes our responsibility. I've seen a lot of loss with regards to people who have been hurt and violated by professionals. So there's been a lot of consequences for boundary violations. And it's much more than just someone's license or credentialing or their standing. So there's much more that gets impacted from boundary violations. Now, I've been loosely using the word boundary violations, but there is a difference. Boundary crossings are something that we may at times engage in. They may not necessarily be harmful, but the one rule of thumb that I would have is that be willing to write it in a chart. So if you're going to loan a patient a book, or if you're going to give them a book, or if you're going to forgive some of their payment, or if you're going to go to their vocational school graduation, their bat mitzvah, if you're going to go to a funeral or something, be willing to write it in the chart. It's not necessarily a boundary violation, but it's not part of the overall treatment that we typically are expected to engage in. If professionals have histories of sexual abuse, then the potential for sexual misconduct goes up with the more severe the trauma was during the course of their life. I mentioned earlier, it's not just the individual, but it's also like the organization and their boundary issues. The institution that we work for could be labeled as, oh, that's where so-and-so worked and they did X. So the whole organization is impacted by, but not only that, the whole profession. So whether it's psychologists, psychiatrists, medical practitioners, nursing, social workers, LACs, whatever the designation is, the whole profession is impacted by boundary violations, not just the organization that the person is working for, not just the individual. And so we saw the Me Too and the Time's Up movement, which really got people talking, and empowerment took place. And that, we saw, I actually published an article about the amount of sexual harassment in graduate and medical education because of, there's cultural harassment that takes place. There's students who are placed in multiple roles as trainees. And so the boundaries are often sort of blurred. So there's a need to be more protective. And then also, obviously, women are more targeted in STEM, as well as people of color and cultural issues that take place. So harassment can come from many different forms, including clients. So we have to be respectful and recognize that clients can also be harassing. This is beyond just etiquette. This is really like the law. And so although we are expected to follow our ethics, there's also laws that are created. So there's a number of ways in which there's fluctuation related to the blending of our ethics and laws and etiquette. And really at the basis of all of this is morality and what is right and what is wrong. And, we sometimes need to seek out assistance and feedback about morality and some of the opportunities that we have to give other people feedback as well. So I don't know, I'm sure most of you know about the Hippocratic Oath, but the curse is, while I continue to keep my oath unviolated, may it be granted to me to enjoy life and the practice of the art respected by all in all times. But should I trespass and violate this oath, may the reverse be my lot. So one thing that really gets minimal discussion is if you, in fact, are attracted sexually to one of your patients. And that often, you're not even supposed to talk about that. But there's opportunity of really being able to seek out some guidance and feedback and understand the reality of where am I in this process? Why am I responding? Why am I reacting? What is it about me? What is it that's going on between the relationship? And what is being pulled out of me? What am I receiving? Whatever it is. So I think that there is opportunity for supervision, but it's often swept under the rug and have a tendency to deny these types of things. So this would have been an exercise I would have done if we would have been in a group. It might be too much to type. So I'll just say that, think about this. If you're maybe at the end, you could type it in as a comment or a question. You live in a small community. You're seeing a couple for domestic violence. Could be, in this case, it's heterosexual. She's a nurse. He's a police officer. Stereotypic here. This couple is doing good therapeutic work, but there's still ongoing work to be done, and they have agreed to continue working on their issues. One morning, you're running late for whatever, and you're stopped for speeding by your local law enforcement. The officer turns out to be your client, immediately refuses to write you a ticket, saying, quote, "I am so appreciative of how helpful you've been to me and my wife," end quote. What do you do? So there are multiple responses here. You could, some people report, "Thank you very much." Some people are like, "No, give me that damn ticket right now. I demand you write me a ticket." Some people start counseling the person on the side of the road and saying, "Is this what you would normally do?" So there's many variations. I'll leave those up to you to make a comment on, and then we'll move on. A lot of times people don't really raise their hand to sort of talk about that scenario, because it's a lot better for us to kind of sit back and watch how other people respond to these ethical dilemmas. And Mark Twain says, it's good to be noble. It's to tell others how to be good is even nobler and a lot less trouble. So a lot of times when we're faced with ethical issues and gray areas, we often try to take this wait and see approach. And I'm going to sort of show you a model that moves beyond the wait and see. Here's some other scenarios that, again, if we had a group process, I would invite us to have some conversations about. And I'll make this PowerPoint available to Gina so she can circulate. So here's a model that I really think is one of the best models I've come across in my career. Looking at making decisions around boundaries, around ethics, this is just a wonderful model to consider. We all are trained, like you have to do a certain amount of ethical training and to understand. So that's a certain amount of knowledge. So we all have a certain knowledge base around ethics and decision-making and boundaries. Then we move into the idea of what is our comfort level? Have we had to how comfortable are we with someone asking us personal information? How comfortable are we with someone reaching out and touching us? How comfortable are we with somebody just giving us a hug? I've had therapists tell me the client just kissed me on the cheek. So there's all this comfort level. How comfortable are we confronting someone? How comfortable are we setting a boundary? Then we go through our experience. So maybe earlier on in our practice and our careers, we might have a certain level of experience as opposed to later on in life and in experience. And then we ultimately come to some understanding and try to make a decision. So I like this to slow down the process and not let you be surprised. The scenario I gave you earlier, which happens mostly with boundary issues and ethical issues, is surprising the unconscious. And people get surprised, and that's when they get caught off guard. And so I'm trying to teach you a model that gives you permission to slow down and say, what do I know about this? How comfortable am I in this scenario? It surprised me. I'm in the grocery store. I'm on a board at my child's school, and I see a client and they're on the board. What has been my experience in the past with this? What are the steps do I have to go through when I make this decision? So just trying to slow down the process. Here are some of the ways, some of the steps of weighing all the possibilities, understanding if there's any conflicts, trying to resolve them, trying to generate some possible alternatives, and then starting to take some action. While I'm taking this action, I'm evaluating my decision, and then I'm examining the implications. A lot of people are uncertain. If we come across people who may be struggling quite a bit, and we don't know how to react to them, we don't know how to support them, we don't know how to help them. There's a big idea that I shouldn't be talking about my peers and my colleagues, that no one really likes a tattletale. And we know that if someone snitches, they often are open to getting stitches. There's a long history of help professionals, dating a good 75 years back. So I invite you to reach out in your respective profession and know that there are processes in place to support people if they're having difficulties related to boundaries, related to ethics, related to professionalism. Telehealth has challenged a lot of us and really stretched our boundaries. However, there are some very clear guidelines for practicing telehealth. And I think that people have just barreled their way into telehealth without considering some of this. And so I think that we have to sort of recognize that if we're practicing telehealth, we have to sort of read these, understand these, and come to some commitment as far as the boundaries go. And I have a few to share. These are just some of the latest books in the past 10 years that I've read, really about technology and the impact on our practice and just society, and the way in which we're sort of recognizing that technology is much broader than just our Zoom call. People really feel this connection, not only through entertainment, but through humanity and through socialization. Decreases our face-to-face and increases discomfort and avoidance, actually. So there's a lot of a need. There's a lot of loneliness that takes place in society. People are reaching out through technology. So I think a more hybrid approach is probably idealistic. This is just a technology check and looking at how often, maybe during this discussion so far, you've checked your phone. What are you looking for? Is it within your eye shot? What would happen if you would turn it off? What kind of feelings would you have internally? And so usually I have people talk about this with the person next to them. People actually check their phone about 85 times a day, spend about 5 hours browsing, and that's back in 2015. I'm sure it's gone up. I'm going to move forward just looking at the reality of threats to confidentiality over telehealth, looking at miscommunications go up with telehealth and, doing work, understanding the knowledge and skills that we have with technology. Not everybody is technologically savvy to be able to understand the delivery of these services over platforms that are telehealth, making sure we have informed consent and recognizing. I mean, I was giving someone the results of some psychological testing for their child, and their other child walked in the room, and I had to stop and say, is it okay to continue speaking because you have someone else in the room? So even just doing that is about informed consent, staying up to date with things, keeping informed consent, recognizing that, the reality of legal risk. Not all states have the same legislation. There's all kind of variations from state to state. Right now, we're under a lot of federal regulations about telehealth, and it's tolerated to a certain degree, but they're slowly starting to pull back. Some of the states have pulled back January 1st. Some of the insurance carriers have pulled back. The government funders have not pulled back, so they're still allowing across the United States care being delivered on telehealth platforms. So these are just some reminders about boundaries, having hours that are respectful, making sure our timeliness is there, being private in a private place. Like I have a fan running to try to decrease the noise outside of this home office, as well as I have a little more privacy here. Model appropriate boundaries with our people and ensure that privacy. There's a lot of apps that are out there. Apps, about 97% of the apps that get downloaded don't get used with beyond the first 3 to 7 days. So there's only a very small list of apps that actually continue to get used. So despite all of our excitement and apps this, apps that, they really don't get used. So we have to really remind people to use these. This is just another scenario. I just want to acknowledge that when it comes to confidentiality, the patient or the client, their needs are met first. The public's protection is next. So sometimes we have to break the patient's confidentiality to protect the public. Then we have our profession, our guidelines and ethics. And then lastly, we're last on the list. So we have 3 levels of hierarchy with confidentiality before ourselves. So just be prepared ahead of time for the possibility of breaches. So that's the key. Have policies, have reminders, have discussions with people well ahead, maybe do reminders. So in part of your orientation, going through boundaries and ethics and just reminding people what the law is and what the limits of confidentiality are, what voluntary commitment and is with regards to their commitment to treatment, what are possibilities of being committed involuntary in your state, and then just doing these maybe 7 days in, 14 days in, so that people have some recognition and understanding. Again, watch the specialness, watch being isolated, watch being attracted to patients, watch excessive self-disclosure. Watch our behavioral changes. We know exactly what's expected of us. What we think is private can often become public in lawsuits, complaints to our professional organizations, grievances in our workplace, reports to our licensing bodies. So these are all ways that what we think is private can easily become public. Smaller rural towns may have different boundaries and different expectations as they see people in different social settings. Just understanding up front, making sure we tell people up front these limitations. And then again, reminding them of confidentiality. Be aware of our dual roles that we have and recognize that we may see people, but we can still maintain a relationship with it, maintaining a certain amount of confidentiality, telling people I will not acknowledge you. And if I see you in public, please don't take offense to that. It's because I don't want you to have to explain who I am and me to have to explain who you are. Just watch unintended consequences for dual relationships. It can become, some sense we lose our expert position. We start to show favoritism if we have a dual relationship, and we can lose other areas. Know yourself, know what's motivating us, be aware of our affect and manage our affect, be a risk mitigator, meaning like managing our risk, discuss, document, look for the warning signs, thinking that somehow you want them to be a friend and not a patient. That's some important self-talk to pay attention to. Be aware of resisting our policy. Well, I can make this exception for our policy. Showing favors, just listen to our self-talk. I'm only doing what's helpful. Everybody else can do this. Why can't I? It's only one drink together. These types of self-talk. We need to know ourselves, our weaknesses, have a plan to consult, have a person that you can get some really direct feedback from, know our policies, have everybody in the office know our policies, don't seek emotional support from our clients. When in doubt about self-disclosure, don't. No, sometimes you have to have people present. Sometimes be cautious of touch, keep records, be willing to write it in a chart, be willing to make exceptions. Don't engage in therapy with these people. These automatically, erode the boundaries that exist. There's a great video here about burnout as professionals and some of the things that make us vulnerable, and finding what makes us smile. What are some things that get back to the roots of what drew us to our profession? We're all vulnerable. We're all under stress, increased scrutiny, increased stress. Well, there's a lot more patients than there are providers. So sort of make sure that we get in touch with things that we really like, our favorite activities, feeling good about ourselves. What are the things that can inspire us? What are we naturally good at? How can we teach someone? What are things that we can do to teach others? What are we good at teaching? And really not having regrets. Can we make sure that we're doing things and don't feel guilty about taking time for ourselves? So, making sure that we're doing something unique, strive towards our knowledge, recognize and affirm our ethics and our ability to be disciplined, and be open and accepting to the financial and the personal rewards we get from our profession. Ultimately, I hope that we're constantly recognizing that the more risks we run, the more interesting and imaginative our theories are about ourselves and about our boundaries and our ethics, the more we stand to learn through our failures. So we should constantly be upgrading dynamic individuals when it comes to the morphing and the changing of our boundaries and our understandings of ourselves. Good fences make good neighbors. And, Alice said, I keep giving myself such good advice. I just never listen. Please don't fall into that position of not listening. And I found this, my name is Philip, but here, you're overthinking this, Phil. I really don't think. I've unfortunately had a lot of professionals that I've had to work with that this has been difficult in their career and had an impact on a lot of people around them. And so whatever you can be sure of this, that you're dreadfully like every other person, not unique. So with that, I'll sort of wrap things up and open it up for questions for Gina to feed me. And I thank you for your attendance and your attention. We have about 5 minutes.
Thank you, Dr. Hemphill. Very appreciative. I just put into the chat for anyone who's interested in providing any questions or comments in regards to Dr. Hemphill's presentation. Please be sure to type that in the chat box below.
Do we have the ability to let people ask the question?
Let's see. Yes, we do. Let me see.
So
I will actually make it open for everyone. If you all can please put yourself on mute, and I will give you access to ask questions. And that way you should be able to.
Looks like Judy has her hand up.
It just says chat is disabled.
Ah, okay. Well, then you can ask away.
I didn't have a question. I just wanted to type in there. That was fantastic.
Thank you, Judy.
Thank you. I was wondering if we could get a copy of the slides.
Absolutely. I'll send them over to Gina Thorne and she can distribute them.
Wonderful.
Absolutely.
Thank you. That was great.
Okay.
You're welcome.
All right. Well, if there are no other questions, we'll go ahead and wrap up. I will have Dr. Hemphill's presentation available, and we'll be sending out the certificates by Friday. Please join us on August 16th when we hear from Paulina Siegel, who will be speaking about moving from annoyed to impactful, working with the selfie generation. And that one will be on Tuesday, August 16th. So Dr. Hemphill, again, many thanks for your engagement with Aspen Ridge Recovery's webinar series, and look forward to hearing more about the amazing things that you're doing. Did you want to mention the newest book that you've just published that people might be interested in taking a look at?
Yeah, I didn't shamefully plug it in the presentation, but I can include it as a slide when I send it to you. But the name of the book is Integrated Care and Addiction Treatment. And it's essentially the past 30 years of my career, sort of pulling things together with regards to how we need to have a collective experience that's holistic for the client. So thank you, Gina. Thank you very much for the invitation.
Of course, absolutely. Well, thank you very much, everyone. I hope you have a great day, and we'll see you next month.
Thank you.
Bye-bye.
Thank you, Philip.